we're going to be going through one of the most common questions that I get asked from doctors. When do you have to worry about recession or gingival issues from overexpanding? Now, in this particular case we're going to be looking at, there's a lot of things that could be done wrong to give this patient a poor result. But instead, if we look at this case properly and we come up with the right game plan, then we know that we can set him up for awesome success. This patient was actually told that he was not a candidate to fix his teeth with Invisalign. And obviously, we're going to show how you do that. And so if you look at the top photo, you're seeing his initial position. Underneath that is going to be his final orthodontic position. And then this patient is going to be getting crowns and veneers done to build back up the worn teeth. So the first time we encounter this patient is when he comes in for a cleaning. He was told by every orthodontist in our city that he was not a candidate for orthodontic treatment. And so to me, when I hear that, I just say, challenge accepted. So my recommendation to all of you guys is going to be to take scans of the patient in the hygiene chair. Now this patient, he knows that he would benefit from orthodontic treatment. If you have a patient who doesn't understand the orthodontic benefits, it's going to be by visually looking at their teeth and going down a path of self-discovery. My recommendation then is take a scan on every single patient, and you can evaluate it with them to show them the chipping and wear and damage that's occurring on their teeth. Now, I like to always use the stone view in the iTero viewer. And the reason why is because it really just shows the detail better. So on this upper lateral incisor, for example, you can see the chipping and wear that's happening. We can obviously see all the gingival issues on the lower incisors. And you just zoom right in and you show them exactly the problems or issues that are going on with their teeth. So we can see how that lateral incisor is getting worn. And if you actually compare it to the opposing side, look how tall that opposing lateral incisor is on the other side, right here. Right? They're completely different in terms of how much tooth structure is left. On the lower teeth, we have recession starting, and we have chipping and wear on those as well. So it's very, very easy just to show the patient these issues and problems, and then they understand the value of fixing their teeth as well. So all we're trying to accomplish from that initial hygiene visit is we just want them to understand that they would benefit from having a conversation about orthodontics. At that point, we book them in for the consult. When he comes in, he says, my teeth are crowded like crazy. That's his initial concern. Now, when we actually take a look and we take the photos and we show him what's going on, what we see is that he has significant crowding. He's got a crossbite on his canine teeth, so his bottom teeth are biting on the outside compared to his top teeth, and he's got lower incisor recession, so the gums are starting to shrink down to the roots of the teeth. And he's got lower incisor recession, so the gums are starting to shrink down, and the roots of the teeth are now starting to become exposed. And then he's got that chipping and wear on the edges of those lower incisor teeth and the uppers as well. Okay, so when we look at his x-rays, we can notice that he does have a previous root canal on his front tooth right here, and also a crown, so a cap on that tooth. And then he's got a root canal on his canine tooth right here. So with brackets and wires, this would be challenging because it's very hard to glue the brackets onto a tooth that has a crown. But we're not going to worry about that because if the attachment doesn't stick to that crown, it doesn't really matter because the Invisalign trays are still going to be able to fully grip that tooth. So it just gives us a lot more flexibility in terms of the tooth movements. Looking from his side profile view, he's got a normal profile and nothing significant is going on. When we look at his smile, you can see obviously that he's got a lot of crowding. Other than that, everything's pretty straightforward. So the outcome simulator, this is, again, such a crucial and important tool in your toolkit here, is being able to actually simulate the position of where his teeth would be at the end of treatment. Again, we're just providing information. And if the patient wants to move ahead with treatment, then that's something that they decide to do. But we're not trying to sell them on anything here. He can go ahead and make the decision of whether he thinks this is beneficial or not based on the information that we're giving him. So on the Invisalign scanner, if you click on treatment goals and then right click on that tooth 4-1, we can go ahead and ask them to virtually remove that tooth. So we can see it right here that it's more yellow. So it's extracting that tooth to give us an option of a treatment plan of if we were to take out a tooth. So this is how it looks. We go adjust outcome. You can see there's a lot of expansion occurring. So those teeth are trying to move so far forward that it's going to lead to possibly recession. So we can update this plan with one tooth virtually extracted. So we can see how much do the teeth actually move now when we extract teeth. Because that's the question, is in this situation, is it better to sacrifice one tooth for the needs of the many, and what will things actually look like at the end of treatment if we do that. A key thing in a situation like this is to show the patient their tooth twin. When this patient first came in, he told me that he's previously talked to 3 orthodontists, and all of them told him that Invisalign cannot fix his teeth. To me, I think that's kind of a strange statement, right? Because it's not, can Invisalign fix my teeth? Teeth don't know whether they're being pushed against by braces, by Invisalign, by a removable appliance, by your finger with the thumb sucking habit. They have no clue what's actually pushing on them. They just know a force is being put on them, and that causes the bone around the teeth to resorb in certain areas and deposit in other areas. Because those teeth have no knowledge of what's pushing on them, it's not a question of, can Invisalign fix my teeth? It's, can I fix that patient's teeth with Invisalign? What I like to do in a situation like this is I like to go ahead and show patients a tooth twin library. So I can show him a patient who has almost the exact same situation going on, right? And this is how I present it in clinic. I present essentially, here is his iTero outcome simulator with 1 tooth removed. So this is what we were just designing the case on. And then in behind these photos, these are of the patient who's his tooth twin. So she's got recession, just like he has recession, right? And the finish is going to be with 1 lower incisor removed. So the middle of his top teeth is going to line up perfectly in the middle of his lower central incisor, just like what happened in her case. I get to very easily answer that question of, well, the orthodontists have told me that this can't be done with Invisalign. I'm never going to contradict them or say anything negative. Instead, what I'm going to do is I just say, I can't really speak to that. All I can tell you is that in this situation, we've treated a patient who's very similar. I don't really see a reason why we can't do the same thing in your case. The other thing that's really valuable from the outcome simulator is that we can actually go ahead and move the teeth to show the patient where the gum lines should ideally be. So again, look at the difference in height between our 1 lateral incisor and then the one on the other side. You can see how different they are. And if we actually put them where they're supposed to be, then you can see how much tooth structure has actually been ground off of those teeth. And so that allowed us to have a conversation, not just about the orthodontics, but also about restoring things at the end of the day. So this is where we get into the financial discussion. Now, the thing that we need to keep in mind when talking to patients is so many times we present things in such a way that prevents people from being able to move ahead with treatment because we're putting limitations in place. So a traditional presentation for finances would be that this case costs $6,300. And in order to start, we need them to put a certain amount down. Let's call it $2,300. And then we're going to take monthly payments over 12 months. Whereas a modern presentation to me flips that on its head. We don't start talking the total price. We start talking about what works for them within the structure of their life. I try to think of it almost like that Price is Right game, Plinko, where the chip falls down and it lands either on the 10,000 or anywhere within the parameters. And so as long as the patient is wanting to move ahead within the parameters that we've set as being okay in our office, then it doesn't really matter to me if they put $2,300 down or $500 down, or they pay the whole thing off. As long as it's within the scope of what we're comfortable with, then it's cool, we're good. So how we would present things differently is, in his situation here, we ask him, do you prefer to have a monthly payment, or do you prefer to pay things off in full and receive a discount? And his answer right off the bat is just, well, I always pay things off in full. I don't like owing anybody money. Okay, awesome. Well, the price then is $6,300. And if you pay in full, you're going to get a discount of $500. That's kind of how we presented our office. So we didn't waste time explaining 5 different options to him to say, hey, here's 0 money down. Hey, here's a payment plan 1, 2, and 3. And here's the pay in full options. Instead, we kind of presented to him, some patients make monthly payments. Others prefer to pay off the entire thing and receive a discount. Do you have a method that you'd prefer? What works better for you? And the total conversion time for him to sign up to move ahead with orthodontic treatment, the entire consult would have been maybe an hour, and the financial component maybe 5 minutes. Because once we show him really the 3 things that he wants to know is, can Invisalign treat my teeth? Can my teeth be fixed with Invisalign is the question he came in asking. How long is it going to take? And how much is it going to cost? If you can answer those 3 things and they're acceptable answers for that patient, they're going to move ahead. So we talk about the difference between doing buccal attachments or putting the attachments on the front of those teeth, or doing lingual attachments, being on the inside of the front teeth. That's the tongue side of the teeth. Now, the difference here is that if this patient is going to put the bumps on the inside of his front teeth, it means that when he bites down, he'd actually hit those little attachments on the inside of his teeth. So if he does do those attachments on the inside, that means that he's actually going to have to eat with his trays in. So when he's ready to have food, he just eats like he normally does nothing differently. Leave the trays in, eat like you normally do. But it is crucially important that he needs to make sure to remove the trays, brush his teeth, brush his trays, and pop them back in right after eating. He cannot leave food stuck in his trays for an hour or 2 hours, and he cannot drink sugary or acidic drinks with those trays in. So if he's going to have pop or soda, energy drinks, ices or Slurpees, anything like that, you have to take the trays out when you're having those things. Because if not, the sugar or the acid is going to get stuck between the Invisalign tray and the tooth, and it's going to start causing cavities. But the benefit is that if a patient is eating with their aligners in, every time that they bite their teeth together, the tray is going to push down more onto the teeth, and the movement of the tray is going to happen faster and more consistently. If the average Invisalign patient taking their trays out for 4 hours a day when they're eating food and waiting to clean them, that means that they're out for 7 days at 4 hours is 28 hours. That's one entire day's worth of time in a week span that they are not wearing their trays. So even if a patient just ate and it took them 5 minutes per meal and they only had them out 15 minutes a day and they're wearing them 24 hours a day, that patient would now essentially have worn their trays for an extra day compared to the patient taking them out for 4 hours a day in the span of a week. So that means that a patient who was wearing their trays for 24 hours a day, all the time, other than brushing their teeth, could actually just change out their trays every 6 days instead of every 7. But then think about the fact that it was one entire day's worth that the trays were out. But when the trays are out, the teeth are also moving backwards. So for one entire day's time, the teeth weren't just not moving, but they were actively moving backwards and trying to shift back to their original position. So that 6 days now turns into 5 days. Now, if you think about the fact that every time that you're chewing and biting and functioning on the trays, that means that the trays are getting pushed onto the teeth more and the movements are happening faster and more consistently. So that means that really, instead of being every 5 days, now we're down maybe to every 4 days because we're actually using their chewing muscles to help move those teeth faster and more consistently. So when we have patients who are eating with their trays in, we actually have them change their trays out twice a week instead of changing them out once a week. Now, I don't tell my patients that it means it's going to be twice as fast. I just tell my patients that it's going to be about 30% faster. That's why I tell my patients that if they're removing their trays to eat with the bumps on the outside, then we're going to be looking at about 18 to 24 months. If they're eating with their trays in and they're not taking them out, then we're looking at about 12 to 18 months of treatment time. Oh, and by the way, I'm Dr. Stephen Schalk, and I'm detailing gnarly cases just like this live with my colleague and friend, Invisalign Diamond provider, Dr. Terry Coddington. Our lectures are designed to help you master Invisalign, transform your practice, and get more cases. Click below to learn more. Okay, so we've made it through the consults, and now we're ready to jump into the treatment plan. How do we actually move ahead with this case? Different goals that we have in our treatment is, first and foremost, we want to make sure that he's finishing in class 1 bite. So we want to make sure that all of his back teeth are interlocked nicely together, which right now, that's super easy. It's already that way. We don't need to change anything. We want to finish with the posterior teeth uprighted. So we want to buccally upright these teeth. We want to fix the crowding on the teeth. And we want to make sure that his midlines are symmetrical. His top midline is going to be going right through the very middle of his bottom lower midline. We want to set this case up to restore worn down dentition, and we want to avoid further recession with however we choose to treat this. Now, you guys kind of know I gave the spoiler already that we're looking to take out a lower incisor, but no matter what we do in this case, we just want to make sure that we don't make that recession worse. So what are our strategies? We're going to be using lingual attachments. We're going to take out a lower incisor. We're going to be using 4mm vertical attachments on the 3-1 and the 4-2. we're going to use a custom staging pattern so that the roots move first, and we're going to make sure that we align the gingival margin, and then we're going to balance out a Bolton discrepancy. So let's jump in. A lot of doctors get very scared when we talk lingual attachments because this means that you're taking control of the plan and you're actually changing the position of these little composite bumps yourself. Now, that's not something to be super scared of. I don't want you to get too worried about it. The first thing is remember we talked about the tooth that has the crown on it? We're just not going to put an attachment on that tooth to start with. But when we look at the other movements, all I want you to do is I want you to think about where are you pushing against that tooth to make a movement happen? And where then would we have an attachment placed to help facilitate that movement? So for the one lateral incisor here to start with, what I want you to think about is if you were to push with your finger right now to move that tooth to the buccal, where would you push? Well, you'd kind of take your finger and you'd push right here, kind of underneath this lip of the attachment on the gum side. And that would cause the tooth to move to the buccal. On this lateral incisor, we want to do two things. One is we want to rotate the tooth, but the second is that we want to push it to the buccal, and we want that tooth to extrude a little bit. So we'd be pushing with one finger on this surface of the attachment, and on the other surface, on the gingival surface, we'd push underneath kind of on this shaded surface right here. So that's how we're going to rotate the tooth, but also extrude the tooth. And so this attachment I learned from Dr. Christian Fournier in Montreal, and he likes to call it his hockey stick. Now he would custom make them on the tooth and then scan the patient. Whereas in our case, we're using the attachment templates to actually create it from the initial Invisalign template. So again, this is not super complicated. All we're doing is just having two attachments on the tooth, one to rotate the tooth and the other one to help extrude the tooth and move it buccally. So that was point number one. Point number two we talked about is we're going to be looking to do a lower incisor extraction. So the first thing is that you want to go ahead and cut the tooth out that's going to be extracted. Because right now this attachment template is going to have every tooth in it, including the one you're going to be taking out. I'd recommend that you take out the tooth the same day that you start the case. Don't take the tooth out first and let them walk around without a tooth in their mouth for a month. That's not going to make you any friends. So instead, take it out the same day you start. And that's why the template then is going to have that tooth in it. So what you're going to do is you're going to take a pair of scissors and you're just going to cut out that individual tooth. You're going to fill up the attachment template. So all these little wells are going to get filled with dental composite. And then you just go ahead and you bond on those little attachments in two pieces. So just cut out the tooth that's going to be removed and throw it away, that little piece. And then go ahead and bond on the other attachments. Then you're going to extract the tooth. You'd stop the bleeding. Just have them bite down on gauze. And then after 5 minutes, you go ahead and you can pop the trays in. But what you don't want to do is you don't want to use a pontic, so a fake missing tooth, for that lower incisor extraction. Now that you've started, the patient on the bottom is going to have an Invisalign tray that's going to have a gap in it. But that's going to be closed very, very quickly. And the Invisalign tray itself is going to help block out the view of anybody noticing that this patient is missing a tooth. Okay, so the next thing we talked about was a 4mm vertical attachment. So you can see that the tooth that's going to be extracted here is going to be this the 4-1. The two neighboring teeth next to it, though, we're going to have vertical attachments on those teeth that are 4mm long. These attachments are going to be very, very important to ensure that the roots of the teeth are moving in the proper direction. If we don't have these attachments on this case, then what's going to happen is the crowns are going to tip into that space, and we're not going to be successful at closing the space by moving the roots. So instructions that I'm going to give to the technician, again, I want you guys to see exactly what I did and to be able to use this right away. So this is what I've told the technician. Place a virtual gable bend on the 4-2 and the 3-1. Now I had said the lingual and the buccal, but in this case, it's going to be on the buccal and both. I later changed that. And we want 4mm vertical attachments. We want them to complete 3 degrees of root tip first. So mesial distal movement of those roots. We want 3 degrees first, and only when the teeth are 25% of the way closing that space, then give another 3 degrees, and then finish with a total of 10 degrees of mesial root tip beyond the normal final position of the 3-1 and the 4-2. That's a lot of words. Let's go ahead and actually show it. So what does this look like? Well, let me jump actually first here. Let's jump in and take a look. So first what's going to happen is the roots of the teeth are going to move together. So the roots move together first, and then we're going to go ahead and it actually simulates these roots almost touching one another. So first the roots move towards one another. Then we finish closing the space between the crowns. And if you actually looked at the simulated position of these roots, they would physically be touching. So let's take a look at the ClinCheck. Remembering this tooth is being extracted. So what happens first is the roots would move together. And only when that space is completely closed, then an extra few degrees of root tip is going to occur. So again, first the roots come together and kiss. Then that space starts to close, and then it finishes with 10 degrees of over treatment. We know that Invisalign trays don't do everything you ask them to do. If they did, then this would be really easy. Invisalign would work on every single case. But we have to know when to finesse the case and make additional movements happen. And so that's what we're doing here. We're overdoing it and over-treating it. So if this theoretically would express, these roots would actually be kind of pointing right at each other. But they're not going to. That's not actually what happens in this case, and I'll show you that in a bit. So again, first the roots come together, then the space kind of closes as they come an additional 10 degrees. And if we go back to our instructions, you can see again, so it was 3 degrees of root tip first. Then when the space is 25% closed, give another 3 degrees. And then at the very end, finish with 10 degrees of total mesial root tip. Okay, what about our upper lateral incisors? You guys know already, lateral incisors are one of the worst teeth in the mouth to try and move. And the reason why is because the crowns on those teeth are so small. So we want to have proper attachments to ensure that those teeth are going to move. We also want to make sure that we have the right spacing and staging around those teeth for the movements to occur. What we're asking the technicians to do here is, as the 1-2 and the 2-2 come out of crossbite, make sure that we have 1 millimeter of space, mesial and distal, to those teeth from the centrals and the canines. This is crucial. Only close this space. Only close this space once we've finished moving the teeth to the buccal. Right? We don't want to close the space prematurely. And add 10 degrees of buccal root torque. So 10 degrees of additional movement towards the buccal on the 1-2 and the 2-2. Now, we could probably dial this back from the 1 millimeter of space between the teeth to be more like 0.5 millimeters. I would do that slightly differently now. Let's take a look. So you can see that the teeth, the central incisor and the canine, they're kind of blocking out this lateral incisor. If you just tried to move this tooth straight to the buccal, there's not enough space. Right? The space here is less than the space here. And so we need to move the central incisor and the canine first to make room. That's the first step. Then the lateral incisor can move straight to the buccal. And then, only then, from this spot here to our final position, then that space can close. Let's look at the actual ClinCheck. So first, we open space, then the tooth moves to the buccal, and then that space closes. Again, this is quite exaggerated because we asked for 1 full millimeter of space between those teeth, which we could have done maybe 0.5 millimeters instead. But the key is here is that there's going to be no tracking issues. These teeth are going to move beautifully into that position because there's a grip around those teeth of 360 degrees of plastic. If you were just trying to move that tooth buccal or lingually here with the interproximal of the teeth covered up, you only have grip of the plastic on the buccal side and the lingual side instead of having it on the mesial and distal as well. Okay, on to point number 5, guys. We talked about how we want to align the gingival margins because this patient has decided that he's going to be doing restorative treatment. So we want to make sure that we control the heights to be essentially centrals and canines are pretty similar in height. And we actually tweaked this a little bit after this photo, but we wanted the lateral incisors to be 1 millimeter lower than the height of the centrals and the canines. Okay, and we're into number 6, the final thing, balancing the Bolton. So if you guys haven't seen our other videos on Bolton discrepancy, we'll be posting those soon. But the Bolton discrepancy is one of the most important concepts to understand in orthodontic treatment. It means that the teeth fit together like a lid fitting on a box. So when you think about it, right, the upper teeth, they fit together perfectly with the lower teeth if you're biting in the proper occlusion. But if the lid and the box are not the right sizes, then things don't fit together properly. A quick break from this challenge case. There's just 1 week left to join Dr. Terry Coddington and myself for our exclusive Invisalign Mastery course in sunny California on February 2nd and 3rd. Learn cutting-edge techniques from top Invisalign experts, boost your skills, earn CE credits, and network with industry peers. Don't just learn Invisalign, transform your practice and your life. So what we see in this case is that he has a bolt-in discrepancy. We can pull up the bolt-in table from the Invisalign ClinCheck, and it tells us that between his lower canine to canine teeth, those teeth are 2.27 millimeters larger than they should be, or inversely, the upper canines between those spans, they're 2.27 millimeters smaller than they should be. So I get asked all the time, is the bolt-in discrepancy, so the difference between how the top teeth and bottom teeth should fit like a lid on a box, is that due to the upper teeth being too small or the lower teeth being too big? Because the table is not going to tell you here. Well, here's a cheap and dirty way that you can figure it out. If you look at the lateral incisor right here, and if that lateral incisor is the same width as the lower incisors, then you have a bolt-in discrepancy. It means that the lid is too small. There's different measurements you could do by looking at the 1-2 and the 2-2. Like even just look here, you can see that the 1-2, the upper right lateral incisor, is 0.7 millimeters smaller than the 2-2. And you can see it, just look, right? This tooth here is way smaller than this one right here. And so we know then that the bolt-in discrepancy is in part because these lateral incisors are smaller than they should be. Now, if we are going to take out a tooth on the lower because we're worried about the gingival recession, then that means that we've now changed the equation of this bolt-in analysis, because the lower incisor that we're looking to take out is about 6 millimeters, 5.88 millimeters. So what this has told us is essentially, right now, the lid and the box don't fit because either the lid is too small by 2.27 millimeters or the box is too big on the lower by 2.27 millimeters. So we're going to go ahead and we're going to be taking out a tooth that's about 5.9. So if the box was too big, but now we've made it smaller by taking out, we cut out some of that box. Now the lid is actually bigger than the box. It doesn't quite fit properly. So we need to do some adjustments on that top arch. Makes sense, right? We're taking out an entire tooth on the bottom. So that means that we're going to have to be doing some IPR, so some smoothing between those upper teeth, to remove a very small amount of tooth structure in order to make sure that at the end of the day, his overbite and his overjet are balanced. 3.6 millimeters is the amount of IPR, the smoothing that we need to do on the upper arch. So if we divide that by 0.4 millimeters per contact, that's giving us about 9 locations of 0.4 millimeters that we need to do this smoothing on in order to balance the lid and the box fitting together. Now, again, I know that's a more complicated topic right now, and I don't want you guys to stress this too much. The main thing is just we want to make sure the lid and the box fit together properly. If we're taking out a tooth on the bottom arch, that means that usually there's going to be a bit more of an overjet, more space between the top and bottom teeth, or as kind of normal people would call it, an overbite. Right? We don't want him to be able to stick his entire pinky between his top and bottom teeth because we took out a bottom tooth, but we didn't do anything on the top teeth. So we're going to plan in these 0.4 millimeters of IPR. So that's just a small amount of smoothing between the teeth, but we want to make sure that we delay that until the contacts between the teeth are actually open. So you can see here, the yellow indicates when that IPR is being done. And on the bottom, you can see it's happening at aligner number 46. So only after we've actually finished straightening all the teeth do we do that IPR, because we need to smooth between these teeth when we actually can access the contact point between them. So if you were going to do interproximal reduction between the central and lateral incisor here, when the contacts are still rotated, you would end up doing the IPR kind of on the central incisor right here, and on the lateral incisor right there. So you'd be removing a very small amount of tooth surface from that tooth, but where you'd be removing it is that you would be removing it kind of from the corner of this one tooth and then off of the lingual surface of the other tooth. Whereas where we want that to be done is we want it to be done right here and right here, and the true interproximal contacts. So again, we want the IPR to be done when the contacts are derotated and we can actually do it on the true interproximal surface and not doing it on the buccal or lingual of the tooth. Now guys, you know me, I'm very detail oriented. I've got a whole set of instructions about how I pass this information along to the technicians. So if you want to know more, check out the Clearly Aligned courses. And I break these different case examples down very, very comprehensively with all the instructions that I use for the technicians, not just for this case, but for every case. So we've made it through our treatment plan. We've got a good plan for him now. So what actually happens? Let's check it out. So this is his initial position on the top, and on the bottom, this is his progress. So we've done an awesome job of lining up the gum lines of these teeth. Now, maybe we intruded those lateral incisors a little bit more than intended, but all in all, like this is very, very good for us to be able to build up the edges of those incisors. So when you look at the different position of this lateral incisor versus the central incisor, look how much more you can visibly see of the cingulum surface of that lateral incisor in comparison to the central incisor. So the difference between those is that the root of the lateral incisor, it's still actually making its way towards the palate. What we need to do is we need that root to move to the buccal towards the cheek side. And as that tooth uprights, you would see less of that cingulum. So that's just a quick and easy way that you can see. If your roots are still tapering towards the palatal side, we need to add in more buccal root torque. In order to determine if the roots are in the proper position or not, what we need to do is look at the cingulum. So the cingulum of the tooth here is going to tell you if the roots are tapering then towards the palatal side or if they're directly underneath the tooth like we see on our central incisors. So if we actually kind of compare the length of the cingulum here, our lateral incisor has a very long cingulum. I mean, we can just look at it too. You can see that this tooth looks like it's tapering more towards the palatal side still. That'll come up later again, but it just kind of gives an idea of things we can notice from our photos very quick and easily, is that this lateral incisor has roots that are tapering towards the palatal versus the central incisors are more upright. We can see that on the lower as well. So this 3-2, this tooth right here, compare how long the cingulum is from this view, and same thing with the other lateral incisor. Now look at our central incisor and you see much less of the cingulum than you do on the other two teeth. So that means that this root is still positioned a little bit more buccally than we want it to be. We want to move this root back lingually so that the cingulums are more even between the three. You'll see that when we get to our next set of progress records. Now in reality, on the updated ClinCheck here, I missed the buccal root torque on the upper lateral incisors. So I did not catch the fact that we needed more buccal root torque as much as I should have. I should have caught that we needed more than what we have planned in there. On the lowers, you can see that we're aligning the edges of the teeth. But from this view, you can see that we're really working on the position of the cingulum here. On this 3-1, you can see that the cingulum is similar to its neighboring teeth. It's not the exact same amount because these teeth are thicker, but it's more of an even profile that's noticeable. So that's all we did in our ClinCheck, is just those minor adjustments to improve those positions. So this is where we're at the end of orthodontic treatment. And this is why I warn the patient before we start that at the very end, we're going to be lining up the gingival margins if he agrees to it, which he did. But that means that we're going to be building up these teeth to be longer. Because if you didn't know that this is what we were intentionally doing, you would think that I'm terrible at my job. But this is all intentional. We're building the foundation in the right spot to then be able to put the walls back. And you can see here, we've aligned the gingival margins, right? We've given space for those restorations to go in place. So this is all completely intentional. We also have completed that interproximal reduction, the smoothing between those upper teeth, so that we don't end up with a giant overjet, right? We want to make sure that this patient's top teeth and bottom teeth are close together and you can't fit your entire thumb between them. So that small amount of smoothing just made sure that the bite fits together properly, right? We're biting in a nice class 1 molar and a class 1 canine occlusion on both sides. Everything is beautifully interlocked together on the sides. Now, we've had very nice arch development on the upper, but you can still see, and this is where I missed it before, when we look at the amount of the position of the cingulum here, this to me sticks out more here and here than it should. These teeth are narrower than the central incisors, but yet if you measure the distance across here to here, they're about the same, or maybe even the lateral incisor is a bit more noticeable. So the root is still tapering more to the palatal surface, but it's okay in this case because he's getting the veneers and crowns done. On the lower incisors, we can see that the teeth are nicely aligned in the arch, and we haven't caused any recession or gingival issues. When we look at the cingulum, this is much better than it was in the last series of photos. Hi there, I'm Dr. Stephen Schalk, and you have got to see this full case in detail. Click below. I'm also going to be teaching and providing CE credits live at a city near you. Check out our tour dates on the screen now. Now, one thing that is so crucially important is to make sure if you're going to be doing restorative treatment, do not, I repeat, do not remove the attachments from the teeth, the composite attachments, until you are prepping those teeth and ready to insert the temporary crowns. I want to show you an example of where I did it improperly here, that I spent all this time intruding the lateral incisor to get the gingiva even with the central and the canine, pretty much. And then we took off the attachments. And we got a new batch of trays for this patient, but as soon as we took off the attachments, this tooth extruded back down again. So look at the height of where the canine was here and the lateral incisor. It was almost the same height. And then look now, right? You can see the space again between the lower canine and the lateral incisor. There was lots of room between those, and now they're almost touching. This patient wore aligners the whole time. There was no time that she didn't wear trays. But because she didn't have the attachments on that tooth, that resulted in that tooth extruding on its own and trying to relapse back into its original position. So how we ask for aligners in the meantime while this crown work is being done is, I have all the instructions on the left so you can check through that, but essentially I'm asking for holding trays that are only going to have a small amount of bite settling movements happening in the back. So there's a little bit of movement occurring, and we only have 15 aligners in total. The patient's going to change them out every 2 weeks, and that allows us to have 30 weeks worth of trays just to hold things in the right position. Like I said, leave on all these attachments because it's going to help prevent the teeth from extruding back down in the front area, in the anterior. So now that gives you essentially 6 months to complete those crowns. Now, one thing we always check for with our cases at the very end, even though we've inserted the crowns now, we check to see if there's any loose contacts. We want to make sure that there's no spots where food is going to get stuck. So we floss between the teeth, and we're going to ask for IPR between any loose contacts. Now, I cover this more in Foundational Systems of Clear Aligners. So if you want to know more about this technique, check out that course. The link is in the description. But essentially, we tighten up any loose contacts with fake IPR, and that is going to ensure that everything is going to nicely close up. This is him after his crowns and veneers are completed. So it doesn't matter that we have no attachments on the teeth anymore, that we've taken them off. We can still make settling movements like this happen. So just tighten up those contacts, and we're good to go. Okay, so let's take a look at his final photos. So this is after his veneers are inserted. Again, perfect midlines between the upper teeth, and the symmetry is there with that lower incisor. You can see how we had recession occurring on those lower incisors. And even with the improved health of the gingiva, like look how much better the gums look here and the teeth look than they did before, right? With the bulging gingiva coming out and the recession starting, you can see kind of the yellow area right here of recession. So now we've got beautiful pink gingiva in a super stable position. The lid fits on the box perfectly. Really nice veneer and crown work to blend those teeth in, especially with the discoloration that had happened on that central incisor previously. Again, beautiful dialed in class 1 occlusion on both sides. Look at the height difference on that lateral incisor. It's crazy, right? The height difference, because we put the gums in the right spot, you would never know that this isn't his natural tooth. And the beautiful thing is because we put the gums in the right spot, we don't need to remove any more tooth structure off of the incisal edge. Instead, we just added back to it. So it made the actual crown prep for the dentist very easy. Now, a tool that's come into play that's going to help out a lot in these cases is using Invisalign's Smile Architect, where we can actually 3D superimpose the patient's teeth onto their face. and build and plan the restorations from the very beginning of treatment. That is going to be a really crucial tool in the future as this continues to be improved. So then we can show the patient an example of what his teeth would look like with restorations in place, whether they're fillings on the teeth or crowns on the teeth. That gives him an idea of what things will look like once he's finished treatment. Okay, and that takes us through his results. I mean, he's thrilled. In total, it took 12 months for this entire treatment plan, right? He was told this couldn't even be done with aligners, and here we are, completely finished, crowns and everything, extremely happy with a very stable and healthy bite that he's aesthetically happy with. Like, this is as good as you could hope for. Now, in terms of case statistics, for those of you who are in our exclusive Facebook page, we'll go ahead and be releasing those. So if you're a dentist and you want to know more about kind of the efficiencies and the business side, our Facebook page is available to anybody who's taken a Clearly Aligned course. So go to clearlyaligned.ca. We want you to be educated to do better treatment for your patients. And so take any Clearly Aligned course, and that'll grant you access to our Facebook page where we drop these exclusives for our members. Come check out our Facebook page. We've got an exclusive community of like-minded dentists working through everything that you are going through or will go through. And so we're here to support you guys.